Good morning, everyone. Myself, Dr. Vikas Reddy. Today, I'm going to present on the topic of GBS. Moderator is Samantha ma'am. Our objectives are introduction of the topic, epidemiology, etiology, triggers, pathophysiology, classification, and typical and atypical presentations, red flag signs to be monitored in ICU admission, diagnostic approach, treatment, differential diagnosis, scoring systems in GBS, and intensivist role in treating GBS. Introduction. GBS, it's an acute immune-mediated polyradiculoneuropathy. It is rapidly evolving areflexic or hyperreflexic motor paralysis with or without sensory disturbance. The pattern of weakness usually is noted as ascending. It is the most common cause of acute flaccid paralysis worldwide. The progression to its peak is usually less than 4 weeks. Incidence is about 2 cases per 1 lakh population, and males are at the slightly higher risk compared to the females. Etiopathogenesis, it most of the cases it will be having either infection or immunization history in the past 3 weeks or any autoimmune condition, and the most common organism which is usually noted is Campylobacter jejuni. The other organism which are found is Mycoplasma pneumonia, Haemophilus influenza, HIV, CMV, Epstein-Barr virus, hepatitis, Zika virus, and dengue. And the vaccines usually, post-vaccine history usually which are tend to be a influenza vaccine, rabies vaccine with the old formulation, and COVID-19 vaccine with where the adenoviral vector. And this is mainly due to the molecular mimicry. Etiopathogenesis. The pathogen once enter the body, the liposaccharides which contain the glycan, this activate the immune system where the B cell and T cell are activated, and B cell this produce the autoantibodies, and whereas the T cells start with the inflammation with interleukin 2 and IF and gamma are activated. Once this host macrophage enter, and they resemble with the peripheral nerve gangliosides, and these cross the blood nerve barrier, and which forms the complement protein, and membrane attack complex deposition takes place, and this leads to the striping of the myelin and direct axonal degeneration and results in the paralysis. This is the same pictorial representation where the antibody binds and complement activation takes place. The nerve injury occurs, and where this macrophage attached to the myelin and cause striping of this myelin, and this cause the demyelinating disease. And when this macrophage enter deeper inside and attach to the axon, these cause the axonal injury, and this axonal injury can be primary or secondary. The secondary, it means once the demyelination occurs, and further when it is progressed or not treated, this even can cause the axonal injury. And the classification of GBS, it has wide variants. Like not all the GBS cases present with the same ascending paralysis. There are wide variants of this. Around among this, sensory motor are most common, which carries around 30 to 80% of the cases, and the pure motor are around 5 to 70%. The other variants are like paraparetic, pharyngeal, cervical, brachial, bilateral facial palsy with paresis, pure sensory, Miller-Fisher syndrome, Bickerstaff encephalitis. Among these, pure sensory and Bickerstaff encephalitis carry less than 1% of the cases. This is the pictorial representation where classical motor and pure motor, this starts with the ascending paralysis, whereas the pharyngeal, cervical, or brachial facial, these tend to have pseudo descending paralysis. The sensory motor variant usually present with the symmetrical weakness and sensory signs, absence of the absent or reduced deep tendon reflexes, and usually this reach the plateau or the peak phase by 2 weeks of their disease onset. Whereas in the pure motor, there are no sensory signs, only the motor weakness is to be seen. Paraparetic, this paralysis will be usually restricted towards the legs, and it can be confused usually with the cord involvement, spinal cord. And pharyngocervical brachial variant of GBS, the weakness is usually pharyngeal, and these patients usually present with dysphagia or dysarthria, and this presence has a descending paralysis. Whereas the bilateral facial palsy with paresthesia, there will be a bilateral facial weakness involvement along with the reduced reflexes and paresthesia. Whereas pure sensory, it is usually confused with the acute peripheral neuropathy and with no other motor deficit. Whereas in Miller-Fisher variant of GBS, the patient will have ophthalmoplegia, ataxia, areflexia with no loss of conscious or sensorium disturbance. Whereas in the Bickerstaff variant, the patient will have impaired consciousness level. This is the small difference between the Bickerstaff and Miller-Fisher variant. And for the diagnosis of GBS, there are two criteria. One is Brighton criteria, which most commonly we use, and one more is the National Institute of Neurological Disorder criteria. In Brighter criteria, it is mainly of carries of three things. One is clinical, the other one is laboratory, the other one is the exclusion of other diagnosis. Among this, we are having level 1, level 2, level 3 of evidence. In level 1 evidence, where we see the clinical diagnosis along with the laboratory findings and eliminating all other alternate diagnoses, such as flaccid weakness of limbs, decreased deep tendon reflexes, and the monophasic pattern of illness, which is between 12 hours to 28 days with a clinical plateau phase, and narrow conduction study pointing towards GPS, and along with the CSF analysis, which is showing cytoalbuminic dissociation, where the WBC count usually is less than 50 and less than 10, it is typically GBS. Whereas in the level 2 diagnosis, it is same as the level 1, but either of narrow conduction study or CSF analysis is enough to diagnose this thing. Whereas in the level 3, only the clinical diagnosis with ruling out the other alternative causes of the weakness is enough. Whereas in the National Institute of Neurological criteria, this requires mainly the clinical diagnosis and with the strongly supportive. Clinical diagnosis such as bilateral weakness of the arms and legs, absence of the deep tendon reflex, and these need is supportive factors like the weakness should last from a few days to 4 weeks, and relatively symmetry should be the prime criteria, along with the involvement of cranial nerves and CSF showing albumin cytological dissociation. And when to doubt, the diagnosis is based on the asymmetry, early bowel and bladder involvement, sharp or band-like sensation on with a definite sensory level, or CSF showing pleocytosis with more than 50 cells. In CSF, usually the when once on examination, it will be showing elevated protein with the normal or WBC count less than 50 cells. Whereas in the routine investigations, rule out for the hypokalemic periodic paralysis, and antibody testing can be done like anti GQ1B antibodies, which is helpful in diagnosis of Miller-Fisher, and neuroimaging to rule out any spinal causes or like transverse myelitis or any cord compression thing can be done. On nerve conduction study, this is the usual normal pattern, the first one, which shows the normal latency with the height. This is amplitude, and which is usually a peak up and down thing. Whereas in the demyelinating disorders, there will be a prolonged latency. The amplitude wise it is the same, where the F latency is prolonged, and abnormal temporal dispersion of the conduction block. It means like on each wave we will be seeing the very like latency and amplitude differences in demyelinating, whereas in Aman or Amsan, where the axonal injury is present, the amplitude is small, but there is the amplitude of this thing is small, but latency can be normal in this. The autoantibodies which are usually tend to be in AIDP are GM1 and are most common, and whereas in Aman it is GD1A, GM1, GM1B, and Miller-Fisher variant it is GQ1B, which is more than 90% times it is positive. The treatment is usually IVI immunoglobulins and plasma exchange. Both have in various studies it has said to be like both are effective, but time of onset like less than 2 weeks of time of presentation. The IV immunoglobulins are better or plasma exchange. But once the duration of treatment when you initiate in the first, if it is more than 3 weeks, then plasma exchange can be considered. Du- and the dose of IV immunoglobulin is 2 gram per kg over 5 divided doses, or 0.5 gram per kg per day or for 5 days. And plasma exchange can be done in 4 to 5 sessions, where we will be replacing around 40 to 50 ml per kg or kg of plasma over 7 to 12 days. Once you we di- once we, once we diagnose GBS and plan for the initial, and when to initiate the treatment or when to start on IV. Whenever the patient is unable to walk or where the disability score is more than 3, especially when it is the less than 2 weeks of onset of the weakness, and the treatment usually which we start is either Plex or IVIG. And mildly affected patients where the disability score is 1 to 2, we can wait starting initiating the treatment, or the treatment can be initiated once the further deterioration has been noted. And whenever once we have started with the treatment of IV immunoglobulin or Plex, and if the patient has reached a plateau phase or recovery, followed by if he is deteriorating again within 4 weeks, it is said to be treatment related failure. Whenever there is a treatment related failure within 4 weeks, then we can plan one more cycle of IV immunoglobulins or Plex. Whereas if this treatment related failure, it is more than three times which occurred in the primary treatment, and it is if this deterioration is even noted after 8 weeks of the treatment, then it is considered as acute CIDP. And during the treatment of this, check every third 1 to 3 hours, check with the respiration, progression of the weakness, swallowing difficulties, or any autonomic dysfunctions or any pain. The complications like DVT, pressure ulcers, and pulmonary infections to be treated. And supportive care like for the DVT prophylaxis, chest physiotherapy, skin care, frequent turning to prevent bed sore, nutrition and fluids to be given, pain management, daily range of motion exercise to prevent the contracture. Tracheostomy is considered if the if patient was on mechanical ventilation for more than 2 weeks. And when to doubt our diagnosis, where initially when we felt that during weakness and all, if the patient is having asymmetry in the weakness and or any severe respiratory dysfunction at onset with the mild limb weakness, or predominant sensory signs at onset with mild weakness, fever at onset, or sensory level or extensor plantar. Definite sensory level usually is seen for the spinal cord or any transverse myelitis. With the extensor plantar response, it means UMN causes. Hyperreflexic, hyperreflexia, early bowel and bladder involvement. Even though bladder and bowel involvement can be seen in GBS, but not early. Where the patient is presenting with the abdominal pain and vomiting, we can doubt this with the nystagmus or altered sensor consciousness, but this can be seen in the Bickerstaff variant of encephalopathy, abnormal routine blood investigation, or CSF when it is more than 50 mononuclear cells, or then it is definitely not GBS. It is something which you are assuming as GBS. Probably it might be some viral encephalitis or something, bacterial cause. And worsening of the symptoms even after more than three treatment related failure or more than 4 weeks, which is usually seen in acute CADP. And the differential diagnosis are encephalitis or brain stroke, spinal cord transverse myelitis, acute flaccid myelitis, see, or any radiculopathy or neuropathy which causing like CMV, HIV, CADP, or thiamine deficiency, diphtheria. Whereas in the neuromuscular junction, like myasthenia, lambertitan, botulism, OPCs, and from the muscle causes, hypokalemic periodic paralysis or acute viral myositis and critical myopathy. There are various scoring systems for the GBS. Among this, the GBS disability scoring is the most commonly used, even for the treatment when to be initiated. And this contains of six grade scores. Zero is healthy, whereas one stands for minor symptoms but capable of running or do manual work, whereas score 2 carries for able to walk after 10 meters with or more without any support but are incapable of running, whereas score 3 able to walk for 10 minutes but need some support, whereas 4 is bedridden and chair bounded. Whenever the patient is presenting with GBS disability score of 4 with the bedridden or immediate plex or IVIG should be initiated, whereas score 5 is requiring assisted ventilation, and score 6 is dead. And ME it is a modified Erasmus GBS outcome score where it can predict on presentation when we check this, and after 7 days when we are doing rechecking this, we will get an idea like the percentage of patients can outcome for of this GBS once after the treatment, and this carries age, preceding diarrhea or MRCM, some score. And the red flag signs to be monitored during ICU or whenever we are looking with the GBS case, where to look the particular signs and whether signs and symptoms where you need the ICU transfer. Like a drop in a single breath count less than 20 indicates ICU transfer, whereas forced vital capacity to be checked every fourth hourly. If the reduction of FEC is more than 30% in 24 hours, need ICU transfer, or If the reduction in FVC is more than 50% in last 24 hours, then there is a need of mechanical ventilation. Or if there is a rule of 20, 30, 40, which means forced vital capacity less than 20 ml per kg, and maximum expiratory pressure where it is less than 30, or maximum inspiratory pressure where it is less than 40, warrants the need of mechanical ventilation. And admission within 7 days of onset of symptoms. This is also a thing to be monitored. And patient is inability to cough, and GBS disability score grade more than 4, inability to lift his arm horizontally, or not able to hold neck flex. And bedside assessment in ICU for respiratory muscle strengthener. The first and most important thing, sensitive and important thing is clinical assessment. Watch, look for tachypnea, shallow breathing, paradoxical breathing, using accessory muscle and breathing, weak cough, weak gag, inability to clear secretion, dysphagia, and nasal speech. Or the single breath count. Ask the patient to take a deep breath and start counting. If the patient can count more than 25, it means normal, but less than 20, 15 to 20, it's a mild weakness where there is the need for ICU admission. Whereas less than 15 is significant weakness, and less than 10 is severe weakness. Once the patient is cannot be counting less than 10, then consider the mechanical ventilation as soon as possible. And forced vital capacity, this can usually needs a spirometry, but in the bedside, using the incentive spirometry, we can check it. Ask the patient to take a deep slow breath and exhale for normally, then followed by ask the patient to inhale and slowly just in hold the balls, like in the spirometry balls, for 2 to 3 seconds. On spirometry, it is usually mentioned like 600, 900, 1200. If he is able to hold the piston of 600 for 2 to 3 seconds, for 3 seconds, so it is like 600 into 3, it is around 800. 800 is his vital capacity which is able to hold. So repeat it for 3 times and hold the best value. Assuming 600 for into 3, it is patient is around 60 kgs. So his capacity is around 30. And measuring the peak cuff flow, this can be done in the bedside using a cuff flow meter. Ask the patient to take a deep breath followed by blow it, and it can be.
Keep this position for the entire time. Blow out and empty your lungs as much as possible. Breathe in deeply to completely fill your lungs with air. Put the mouthpiece between your teeth and close your lips tightly. Do not put your tongue on the mouthpiece. Blow out as hard and fast as you can through the mouthpiece. The sliding marker will move up the scale. Look at the number on the meter to see where the marker stopped. Repeat the steps and measure your peak flow 3 times. Record the highest.
So usually, whenever there is an adequate cuff reflex, the peak cuff flow can be, usually will be more than 300. But when it is less than 160, then it is sent to be as ineffective cough, and where the patient needs assistance for to clear his secretions.
So we're going to do the maximum.
This is for measuring the maximum inspiratory and maximum expiratory pressure.
Expiratory pressure test. This is the manometer. Before the test starts, you want to make sure that the red reference arrow is on the top of the black arrow. Whenever the subject blows through it, the black arrow will move, and the red arrow will stop at the peak point. That's how you read it. So this is the mouthpiece that you're going to use. You have the 3 ridges, with your teeth on the ridges, and bite down tightly. and then wrap your lips around it so there's a tight seal. And what you're going to do is you're going to take a full breath in through this device, and then blow out as hard as you can. And the trick here is to listen for when there's no more air coming in, that's when you know that the lungs are full. So at that point, when you don't hear any more air coming in, that's when you ask them to blow out as hard as you can. Okay, so we're going to put on the nose clip. Take one full chest of air in, breathe in. Now blow it out. And stop. So now you can see the red reference arrow showing the peak amount of pressure in centimeters of water. And we would repeat that test 3 times total. Okay?
Let's say you've done so.
So that's the last one. So then for the inspiratory pressure test, you're going to put the needle below the black needle. So the red reference needle is going to go below the black needle on this one. Because the pressure is negative, it's going to go in the opposite direction. So then we have to take this mouthpiece, put it on the other side, so that it offers inspiratory resistance. And then this test is a little bit different. Take a little bit of air into your lungs first, so you have something to blow out through this mouthpiece. So take a little bit of air into your lungs, put it in, and then in as hard as you can. Okay, you have to blow out through the mouthpiece. I'm going to listen for no more air, so I know that your lungs are empty, and then I'll ask you to breathe. So we put the nose clip on, bite down, take a little bit of air into your lungs first. Now blow out through the mouthpiece. Now in. And stop. And now you can see the red reference needle showing me.
This is for the maximum inspiratory and expiratory pressure, which can be done in the bedside. And intensivist role in GBS. Early involvement of intensivist is required in almost all of the patient with the rapidly progressive weakness. The main role is early recognition of the respiratory failure and autonomic instability. The serial monitoring of the respiratory parameters is mandatory. The decision of elective intubation should be done in the by intensivist. And hemodynamic instability must be anticipated. Ventilator management must be required for prolonged duration, and prevention of ICU complications improves the outcome, and close coordination with the neurology team is required. Respiratory monitoring in ICU, the pulse oxy alone is not enough. Forced vital capacity to be checked every 4 to 6 hourly, and negative inspiratory pressure and maximum expiratory pressure to be monitored. Trend of decline is more important than a single value, whereas rapid fall in FEV suggests that impending respiratory failure and elective intubation to be considered. Bulbar weakness increases the risk of aspiration, and early ICU monitoring reduces need of emergency intubation. And predictors of the rapid respiratory failure are rapid progression of the weakness within 7 days increase the risk, and facial and bulbar weakness predicts the ventilatory failure. Neck flexor weakness correlates with the diaphragm weakness, and the single breath count less than 15 indicates severe weakness. Whereas the rule of 20, 30, 40, as we discussed before, and autonomic dysfunction predict the severity of the disease. And role of NIV in GPS. NIV has limited role in GPS. It may be used only when there is a early respiratory muscle weakness and presence of the bulbar palsy. Poor cough increases the risk of aspiration, and rapidly progressive cases should be managed cannot be managed with NIV. NIV failure may delay life-saving intubation. Continuous monitoring is required if NIV is tried. Most severe cases eventually need invasive ventilation. And when to escalate to CPAP from on NIV failure, whenever there is a rise in PCO2 or increasing in respiratory rate or falling in the vital capacity require escalation. Inability to clear the secretions indicates the need of intubation. Bulbar weakness with aspiration risk requires airway protection. Autonomic instability favors early invasive ventilation. Patient exhaustion is indication for the intubation, and elective intubation is safer in than emergency intubation. When to intubate the patients of GBS, where the vital capacity is less than 15 to 20 and single breath count less than 15, where the severe bulbar palsy, hypoxia or hypercapnia which indicate the respiratory failure, and rapid progression of the weakness requires the airway control. Inability to cough might require intubation. Altered sensorium requires airway protection, and severe autonomic dysfunction. Precautions before intubation. Autonomic instability may cause severe bradycardia. This to be noted. Asystole may require frequent occur during suctioning, and continuous ECG monitoring is required. Atrobin should be kept ready if on intubation, as it can cause brady. Uh, Short-acting sedatives or antihypertension should be preferred than the longer one. On antihypertensions like labetalol should be used. Avoid excessive vagal stimulation or hemodynamic support, and experience airway management is required. On ventilator management, a restrictive pattern is most common on the ventilation. Ventilation may be required in several weeks. Frequent suction is required as patient usually present with a weak cough. Chest physiotherapy should be started early. Sedation should be minimized when possible. Nutrition should be started. Daily weaning assessment should be done. Autonomic parameters must be monitored continuously. In tracheostomy, to be considered when there is a mechanical ventilation used for more than 10 to 14 days. Repeated failed extubation favors tracheostomy, and severe bulbar weakness and excessive secretions favor tracheostomy. Prolonged ICU stay or early tracheostomy may be reduce ventilator pneumonia, and decision should be individualized. Team discussion is recommended. And criteria of extubation are vital capacity more than 15, or inspiratory pressure stronger than 30, or a patient is having effective cough and minimal secretion burden. Bulbar function is adequate or hemodynamically should be patient is stable. Gas exchange is normal. Whereas autonomic dysfunction occurs in severe GBS, may cause tachycardia or bradycardia, hypertension, hypotension. Continuous monitoring is required. The short-acting drugs are preferred over the longer-acting. Severe bradycardia might require pacing. Hypotension should be treated carefully, whereas sudden cardiac arrest may occur in most of patients. The complications, ICU complications like DVT prophylaxis or frequent turning position, chest physiotherapy, early nutrition, and pain management to be done. The range of motion exercise is required to prevent the contracture, and asepsis prevents infection. Delirium prevention is important, whereas early rehabilitation improves the outcome. This is a 10-step management of GBS, with, uh, which says that the immunoglobulin and plasma exchange are the core treatment of these things. The treatment dose and everything we have discussed in the previous. The efficacy is same for both, but selection of IVIG is preferred first as it is easier to administer, whereas um, um, plasma exchange is not available in all the places. And corticosteroid, the evidence is limited and has no significant role in treatment of the GBS. And when to start on treatment, as we discussed previously, like when the patient is unable to walk independently for more than 10 meters, or shows rapid progression of weakness, having severe autonomic and swallowing dysfunction. Critical timing, usually this is IVIG or Plex, whenever it is started, it should be started within 2 weeks of weakness. And Plex is usually preferred after 4 weeks. In Miller Fisher, sir, yes, within 4 weeks. And in Miller Fisher variant, the treatment is generally not recommended, as pure Miller Fisher variant has a good outcome and even without treatment, the patient may improve within 6 months. And the treatment related fluctuations TRF usually occur in 6 to 10 percent of the patient, where the deterioration occurs within 4 weeks of initial improvement. Common practice is to repeat the full course of IVIG once the formal evidence is limited. Whenever there is an insufficient initial response, about 40% do not improve within 4 weeks of standard treatment. There is currently no evidence of repeating the uh, treatment in cases improves outcome. Acute onset of CIDP, around 5% of the patient experience the repeated relapse leading for the diagnosis of CIDP, whereas walking ability, 60 to 80% of the patients independently walk after in the 6 months of the onset of disease, whereas recovery is most of the extensive cases will be recovered from 1 to 5 years. The mortality is around 3 to 10% with optimal medical care, and cause of death is usually cardiovascular or respiratory. Long-term residual weakness and neuropathic pain and fatigability will be the most common residual complaints of the patients of GBS. And prognostic tool like modified RMS GBS outcome score, which can predict the probability of walking after 6 months. And recurrence of GBS is rare as it is a monophasic typical pattern of illness. And rehabilitation, early specialized rehabilitation involving physical and occupational therapy is crucial for restoring the function. Whereas this is Article 2 in the this study has come after the outbreak of the Pune and published in the JAPI. Say is like even these articles accepts what the previous article which we have discussed with the treatment and the ongoing regarding treatment related failure, and they even say that the corticosteroid has no role in the treating this patient. And uh, like now I would like to say a few things on nerve conduction study. On nerve conduction study, we usually measure the conduction velocity, amplitude, and latency. This is measuring the sensory and motor, where the latency mean uh, the latency is from the stimulus to the onset of the action potential, whereas the amplitude is the height of the wave, where it shows response and the reflex of the axon integrity. The latency mean for the myelin integrity, whereas the amplitude mean the axon integrity. And the conduction, it is the speed of impulse transmission, and whenever there is myelin integrity is lost, the conduction is lost, and where you will be seeing the prolonged conduction velocity or conduction blocks. And this is the normal wave where the amplitude is normal, and in the demyelinating the amplitude will be normal, but there will be a prolonged latency and the conduction block. And whereas in the axonal, the wave height of the wave is smaller, but it looks like the normal ones, but the latency can be normal or prolonged. So whenever we are seeing the demyelinating or axonal neuropathy picture, in demyelinating we will be usually seeing the prolonged latency, and the conduction velocity will be decreased and conduction blocks is seen, and delayed onset. And these demyelinating like AIDP, CIDP, Charcot-Marie-Tooth disease, and all this usually these demyelinating disease have good outcome among the variants of GBS, whereas the axonal thing where the amplitude is decreased, latency can be near normal, and velocity is slow, but the normal shape of the waveform and no dispersion is seen. whereas in demyelinating, temporal dispersion is seen. And the axonal like Aman, Amsan, and diabetic neuropathy, this usually, if we find these waveforms, we can assume there will be a poor prognosis of the outcome. Thank you.